imagine walking into an emergency room. You're you're experiencing this crushing, radiating chest pain.
Right, the classic presentation.
Yeah, exactly. You're sweating, you're short of breath, and I mean, you are fully, completely convinced that you are having a massive heart attack.
It's terrifying.
Oh, absolutely. So the doctors rush you in, right? They hook you up to the monitors, they run the scans, and then the attending physician walks back in, looks at your chart, and tells you your stomach has basically migrated into your chest.
Yeah, it's a profound shock for patients. I mean, they come in expecting a cardiac diagnosis, a failure of their cardiovascular system.
Right.
And instead, they're handed, well, an architectural diagnosis, a profound failure of their internal structural engineering.
It sounds like a bizarre piece of science fiction or some kind of weird carnival trick, honestly.
It really does. But it's a surprisingly common, entirely physical reality for millions of people.
And that is exactly what we're exploring today. So for you listening, whether you're currently chewing on an antacid, dealing with an annoying bout of heartburn, or you're just insanely curious about the mechanical engineering of your own chassis, welcome to this extensive deep dive.
It's going to be a fascinating one.
Oh, totally. We are looking at a space inside the human body where biology meets just pure, relentless physical mechanics. And we have a truly incredible stack of sources for today's exploration.
We do. We're pulling directly from expert surgical notes compiled by Major Munish Chauhan. He's a general surgery registrar.
Right, alongside the latest NICE guidelines, so that's the National Institute for Health and Care Excellence, detailing the pathophysiology, the diagnosis, and the clinical management of a condition known as hiatal hernias.
And Major Chauhan's notes are, well, they're particularly brilliant because they don't just give you the surface-level symptoms.
No, they go deep.
Exactly. They lay out the absolute essential core of this topic, taking the condition apart piece by piece, from the initial anatomical blueprint all the way up to the operating table.
And our mission today is incredibly ambitious. I mean, we are going to take you from the microscopic cellular pressure dynamics of the human diaphragm. So we're talking PhD-level curiosity about how things work on a biochemical level.
Right down to the cellular receptors.
Exactly. All the way up to the high-stakes surgical decision-making that happens under the bright lights of the operating room. We're going to cover the kind of complex, high-wire matrix suited for FRCS level senior surgeons.
It's a huge journey.
It really is. Okay, let's unpack this. What exactly is happening inside the body when we use the term hiatal hernia?
So to give you the absolute foundational definition, a hiatal hernia occurs when a portion of the stomach literally protrudes or herniates through the diaphragm and up into the thoracic cavity.
Which is your chest.
Right, your chest. And if we connect this to the bigger picture, you have to understand that this isn't just a simple stomachache or a minor bout of indigestion that you can just ignore.
Right. It's a lot more structural than that.
Exactly. It's a fundamental disruption of the normal anatomy and the functional integrity of your upper gastrointestinal tract.
Because in the human body, I mean, a disruption of anatomy basically always guarantees a disruption of function.
That is the golden rule of physiology. Anatomy dictates function. Always.
Makes sense.
So when an organ as active and, frankly, volatile as the stomach moves into a space where it simply does not belong, the consequences just cascade.
So what are we talking about symptom-wise?
Well, the outcomes can range from what many people experience as highly annoying chronic acid reflux all the way up the spectrum to acute life-threatening complications.
Like what?
Like tissue necrosis, where parts of the stomach literally begin to die because their blood supply has been choked off by the surrounding muscle.
Wow. It's genuinely wild to think about your organs just, migrating, shifting around in the dark inside you.
That's a disturbing thought, yeah.
So to really understand how this happens, we need to visualize the blueprint. We need to look at the architectural breakdown of the diaphragm itself and the specific, highly vulnerable opening called the hiatus.
Let's picture that blueprint. The diaphragm is not just some thin membrane. It is a massive, incredibly powerful dome-shaped sheet of skeletal muscle.
You can picture it sitting right there at the base of your rib cage, right?
Exactly. Its primary job, as most people learn in basic biology, is to facilitate respiration. It contracts and flattens downward to create negative pressure, pulling air into the lungs.
And then it relaxes and bows upward to push the air back out.
Right. But structurally, it serves an equally vital load-bearing purpose. It acts as a physical, dynamic bulkhead.
A bulkhead, like in a submarine.
Exactly like that. It is the floor for the thoracic cavity of the chest where your delicate heart and lungs live, and it's the ceiling for the abdominal cavity, where your stomach, liver, and miles of intestines are just packed tightly together.
So it's this structural bulkhead separating the high-oxygen heart and lung zone from the messy, highly acidic digestion zone.
A bulkhead separating two entirely different pressure systems, which is the key point we'll get to later.
Right.
But because these zones are separated, there has to be a physical pathway to get food from your mouth down through your chest and into your stomach to be digested.
You need plumbing.
You need plumbing.
Yeah.
So the diaphragm has a natural opening built into it, a structural weakness by evolutionary design, if you will.
And what's that made of?
This natural opening is formed by muscular pillars called the crura, and the opening itself is called the esophageal hiatus.
And the hiatus has exactly one job, according to the notes.
One job only. It is a custom-fitted aperture designed solely to let the esophagus, the food pipe, pass through the diaphragm so it can connect to the stomach sitting immediately below it.
Just a single pipe.
Right. In a healthy human, it is a tight, perfectly engineered seal.
Okay, so we have this beautifully engineered muscular bulkhead and a custom-fitted hole for the plumbing. What actually goes wrong? Like, what is the microscopic pathophysiology of the herniation when this natural opening is compromised?
Well, when that hiatus widens or when the microscopic connective tissues anchoring the esophagus to the diaphragm begin to weaken and fray.
Wait, they're actual anchor tissues.
Oh, absolutely. Specifically, a structure called the paraoesophageal ligament. It's made of elastin and collagen fibers. When that frays, the seal is broken.
Oh, I see.
And the stomach, which normally sits securely anchored right below the diaphragm, finds the path of least resistance and just pushes up through that hole. It herniates.
Wow.
And when this happens, it profoundly alters the intricate pressure dynamics between the stomach and the esophagus.
Okay, let's pause right there because I really want to understand the mechanics. Why are those specific pressure dynamics so important? If the stomach moves up an inch or two, why does the whole system just break down?
To understand that, we have to look at the lower esophageal sphincter, or the LES.
The LES.
Yeah. The LES is a specialized ring of smooth muscle at the very bottom of the esophagus, right at the gastroesophageal junction where it meets the stomach. It operates as a critical biological valve.
Okay, so a valve, how does it function normally?
When you swallow, the LES relaxes to let food drop into the stomach. The moment the food is through, it clamps tightly shut to prevent highly corrosive stomach acid from splashing back up into the delicate esophagus.
Makes sense.
But here's the critical engineering detail, and this is FRCS level anatomy. The LES does not work alone.
It has backup.
It relies entirely on external structural support. In a healthy person, the muscular crura of the diaphragm literally hug the sphincter.
A physical hug.
Yes. As the esophagus passes through the hiatus, the diaphragm wraps around it, providing a physical pinchcock action. It acts as an external muscular clamp that reinforces the internal valve.
Oh, wow. So when the stomach pushes up through the hiatus?
The LES is dragged up into the chest with it. That critical anatomical relationship, that external hug, is totally lost.
Okay, I want to use an analogy here to make sure this is crystal clear for you listening. Imagine a load-bearing floor in your house, and there is a perfectly sized hole cut out for a straight, narrow plumbing pipe to pass through.
I like this.
Now imagine that plumbing pipe is subjected to immense upward force, and it shifts upward. Because it shifts upward, it drags the wider, thicker part of the plumbing joint, the tank attached below it, right up through that narrow hole in the floor.
Right.
You now have a bulky structure wedged into a hole meant for a narrow pipe. According to our sources, this exact scenario describes the most common type of this condition.
Yes, the sliding hiatal hernia, which accounts for a massive 95% of all cases.
95%. That's huge.
It is. In the clinical terminology of the surgical notes, the gastroesophageal junction, the exact point where the esophagus connects to the stomach, it slides upward through the hiatus into the posterior mediastinum of the chest cavity.
Right.
And because the stomach is tethered to that junction, a portion of the gastric cardia, which is the top part of the stomach, slides right up along with it.
So the valve itself has just moved into the wrong room.
It has, but it's much worse than just being in the wrong room. It is now in a room with a completely different atmospheric pressure.
Right, going back to those pressure zones you mentioned.
Exactly. The thoracic cavity, your chest, operates under negative pressure. It has to in order to act like a vacuum and pull air into your lungs.
Right.
Conversely, your abdominal cavity operates under positive pressure because it is packed with organs and fluid.
Oh, I see where this is going.
Yeah, so suddenly you have this incredibly important, slightly weakened valve sitting up in a negative pressure vacuum zone, and it has completely lost the muscular supportive hug of the diaphragm.
It's sitting in a vacuum without its external clamp.
Exactly. The barrier fails completely. Without the diaphragmatic support and being pulled open by the negative pressure of the chest, the LES simply cannot maintain enough resting tone to prevent stomach acid from flowing backward.
And this anatomical and pressure-based failure is the direct mechanical cause of gastroesophageal reflux disease.
Commonly known as GERD.
Yes, it's pure physics.
Yes.
The valve is displaced, the pressure gradient is inverted, the external structural support is gone, and the acid just flows up.
It's a perfect storm for acid reflux.
That perfectly explains the 95% of cases, but our sources draw a massive bright red line when it comes to the other 5%.
The paraoesophageal hiatal hernia.
Right. Major Chauhan's notes highlight this as the highly dangerous 5%. So let me push back on the physics we just established.
Yeah.
What does this all mean if the junction actually doesn't slide?
That is the defining anatomical feature of the paraesophageal type, and it completely rewrites the clinical rulebook. In a true paraesophageal hernia, the phrenoesophageal ligament holds strong at the junction. The GE junction, that crucial valve area, it stays securely anchored in its normal position below the diaphragm. It does not slide up to the chest.
Okay, so the valve is safe.
It is. However, the hiatus itself, the hole in the muscle, is still widened and weakened. So what happens is that the uppermost part of the stomach, the gastric fundus, finds that weakened gap and bulges up through the hiatus beside the esophagus.
Para literally meaning beside.
Precisely. Beside the esophagus. The stomach is essentially squeezing itself up through that opening right next to the food pipe, ballooning out into the chest cavity while the valve stays put.
What's fascinating here is how the clinical symptoms completely diverge based on that one microscopic difference in how the tissue tear.
It's incredible.
Because the GE junction hasn't moved, the valve is still largely supported by the diaphragm, right? And it's still sitting in the correct pressure zone, which means
these patients often do not experience the typical burning acid reflux or GERD symptoms. Their LES is usually still functioning normally, maintaining a tight seal.
wait, if they don't have the chemical burn of acid reflux, why on earth is this categorized as the dangerous 5%? Why is the surgical team so worried about this one?
Because while they aren't facing a slow chemical burn, they are sitting on a mechanical time bomb.
A time bomb.
Yeah. When a portion of the stomach herniates up beside the esophagus, it can easily become incarcerated.
Incarcerated meaning trapped.
Trapped, yes.
Hmm.
And because the stomach is a large, highly mobile organ pushing through a relatively rigid muscular hole, it is incredibly prone to something called gastric volvulus.
Volvulus, that just sounds ominous.
In surgical terms, volvulus means the organ twists on its own axis.
Oh, wow.
Imagine taking a long, partially inflated balloon, pushing the middle of it through a tight ring, and then twisting the balloon on the other side.
That sounds incredibly painful.
It is. When the stomach twists, and at the FRCS level, we usually refer to this as organoaxial volvulus, meaning it twists along its long axis, it creates an absolute impenetrable mechanical obstruction.
Nothing can get through.
Nothing. Food, liquids, and even the stomach's own secretions cannot pass through into the intestines, but the danger goes far beyond a blockage.
What's worse than a total blockage?
That twisting, or simply the tight, vice-like squeezing of the stomach tissue by the diaphragmatic hiatus, leads to strangulation.
Strangulation of the actual organ tissue.
Yes. The delicate blood vessels supplying that herniated portion of the stomach get pinched off. When arterial blood supply is cut off and venous blood cannot drain, the tissue rapidly undergoes ischemia.
A severe lack of oxygen.
Right. And if a surgeon does not intervene urgently to untwist the organ and restore blood flow, that ischemia progresses to necrosis.
Tissue death.
The stomach tissue literally begins to rot and die inside the chest cavity. The wall of the stomach weakens, it perforates, and it spills highly toxic gastric contents directly into the chest.
That sounds fatal.
It is a catastrophic, overwhelming, and highly lethal surgical emergency. So, to summarize the architectural breakdown, the sliding hernia is primarily a chronic issue of chemical irritation from displaced acid, while the paraesophageal hernia is an acute issue of mechanical danger and potential organ death.
That is a staggering contrast. It perfectly highlights how tiny, localized changes in microscopic architecture dictate massive, life-altering changes in clinical outcomes.
Absolutely.
Which leads us to the next massive piece of this puzzle, the pressure cooker, the epidemiology, and the risk factors.
Right, who gets it and why?
Exactly. We know what these hernias are mechanically, but who is getting them, and more importantly, why. Let's look at the demographics pulled from the sources.
The numbers are pretty revealing.
They really are. The overall prevalence of sliding hernias is estimated to be around 5% in the general population, but then you introduce the element of time. Aging drastically changes the math here.
It certainly does.
Over half of all adults over the age of 60 have some degree of sliding hernia, over 50%. Though the sources are careful to note that many of these are completely asymptomatic.
It becomes an incredibly common feature of human anatomy as we age. And for the paraesophageal hernias, while they are much rarer overall, they generally start appearing in patients over the age of 50.
Okay.
They are particularly prevalent in obese individuals, and statistically, they are significantly more common in women than in men.
The surgical notes mention that the gender disparity is likely due to complex differences in abdominal pressure dynamics and hormonal factors throughout a lifespan.
Yeah.
But I want to focus on that central underlying concept you brought up earlier, pressure.
Yes. Pressure is everything here.
If we look at the physics of the risk factors outlined in the NICE guidelines, it seems like intra-abdominal pressure is the undeniable villain of this story.
It is the absolute driving force. If you want to understand the why behind those demographics, you have to stop thinking of the abdomen as a soft belly.
What should we think of it as?
You have to start thinking of it as a sealed, highly pressurized container. We are dealing with Laplace's law and fluid dynamics.
Going back to physics again?
Always. Any factor that increases the overall pressure inside that sealed container, or any factor that weakens the muscular walls of the container, is going to force whatever is inside to find an escape route.
And the path of least resistance is always going to be that natural, pre-existing hole in the diaphragm, the hiatus.
Exactly.
So let's break down those pressure multipliers one by one. If we're talking about pure intra-abdominal pressure, I imagine the first major factor, obesity, would just be a relentless 24/7 mechanical load on that diaphragm.
The physics of obesity here are profound. Increased body mass index, or BMI, particularly visceral adiposity.
Which is the fat stored deep inside the abdomen around the organs, right?
Right. Visceral adiposity translates directly to excess physical mass occupying a limited space. This excess mass constantly compresses the abdominal cavity from the inside out, creating a chronically elevated baseline of intra-abdominal pressure.
So it's just pushing constantly.
It is a relentless, unrelenting, 24 hours a day physical force pushing the stomach upward against the underside of the diaphragm.
Wow.
Over time, that constant grinding upward pressure stretches the paraoesophageal ligament, it widens the hiatus, and it physically pushes the stomach through. This is exactly why obesity is such a profound risk factor, particularly for driving those dangerous paraesophageal hernias.
It's just a constant mechanical load that never lets up.
Yeah.
What about pregnancy? The sources highlight this as well.
Pregnancy acts on the entire system in two distinct compounding ways. Mechanically, the expanding uterus acts as a massive physical wedge.
Okay.
As the fetus grows, the uterus takes up more and more space in the lower and middle abdominal cavity, heavily compressing the organs above it and dramatically increasing that upward pressure vector against the diaphragm.
So that's the physical part.
Right. But there's also a critical chemical or hormonal component. During pregnancy, the body releases high levels of hormones like progesterone, which are designed to relax smooth muscle and ligaments to accommodate the growing baby and prepare the pelvis for childbirth.
Oh, I see where this is going.
Yeah. However, these hormones are systemic. They also inadvertently relax the muscle tone of the diaphragmatic crura and that crucial lower esophageal sphincter.
So pregnancy acts as a massive physical wedge, increasing the pressure while simultaneously deploying chemicals that weaken the very defense mechanism meant to hold that pressure back.
Exactly. The hardware is stressed and the software relaxes the guard. It's a perfect storm for developing a sliding hiatal hernia.
And then the sources list chronic constipation, which at first glance seems totally localized to the lower GI tract. How does a problem in the colon end up tearing a hole in the diaphragm near the heart?
It comes back to the physics of acute pressure spikes. The physical act of straining during difficult constipated bowel movements involves a physiological action called the Valsalva maneuver.
The Valsalva maneuver, what's that exactly?
You take a deep breath, you hold it by closing your vocal cords, and you bear down using your abdominal wall muscles. This creates a massive, sudden, acute spike in intra-abdominal pressure to force stool out.
Okay.
Doing this chronically, straining intensely day after day, year after year, it acts like a hydraulic battering ram against the underside of the diaphragm.
A hydraulic battering ram. That paints a picture.
In an older individual whose hiatus might already be weakening, those daily pressure spikes can easily force the stomach upward into the chest cavity over time.
Which brings us back to age.
Age is the universal factor of tissue degradation. Over time, the tissues around the hiatus, the skeletal muscles of the crura, the elastin and collagen fibers making up the ligaments that hold the esophagus in place, they just naturally weaken.
They lose their stretch.
They lose their youthful elasticity and their resting tone. It's cumulative structural fatigue. So the exact same amount of daily abdominal pressure that a 20-year-old's robust diaphragm can easily resist might be more than enough to push the stomach through the weakened, frayed hiatus of a 70-year-old.
I want you, the listener, to just take a second to really think about these risk factors. We aren't talking about catching a virus or a random genetic mutation here.
No, not at all.
We are talking about cumulative physical stress on a single vital muscle over decades of a human life. Every time you lift something heavy at the gym, every time you strain, every pound of extra pressure carried around the midsection.
It all adds up.
It does. Here's where it gets really interesting. Developing a hiatal hernia is as much an issue of mechanical wear and tear as it is an issue of biology. It's like the shocks going out on a car after 100,000 miles of driving on rough roads. It is an anatomical failure driven by chronic mechanical stress.
That is the exact perspective FRCS surgeons take when evaluating these patients. They are looking at a structural failure.
So, the architecture has failed. The stomach has moved. The pressure has won. This naturally brings us to the clinical presentation and the diagnostic maze.
Because knowing what's happening mechanically is just the start.
Right. Knowing exactly what is happening mechanically in an anatomy textbook is one thing, but figuring out what the patient sitting in front of you is actually feeling is another entirely. And our sources show a massive divergence in symptoms between the sliding and the paraoesophageal types.
Yes, the anatomical differences we discussed, whether the valve slides or stays put, dictate entirely different patient experiences. The symptoms are the outward alarm bells of the internal structural problem.
Let's lead with the sliding hernia symptoms first. We know the GE junction has slipped into the chest, the negative pressure has pulled the valve open, and stomach acid is freely splashing up. What does that actually feel like for the patient?
The absolute hallmark symptom is heartburn, but we need to be very specific about what true clinical heartburn is.
How so?
It is a severe, radiating, burning sensation right in the center of the chest, directly behind the sternum or breastbone. It is the literal physical sensation of highly acidic gastric juices, which, by the way, have a pH similar to battery acid.
Wow, battery acid.
Yeah, it's chemically burning and irritating the delicate squamous epithelial lining of the esophagus, which is absolutely not designed to handle that level of acidity.
And when does this usually happen?
Patients typically report that this burning is significantly worse after eating a large, heavy meal, or crucially, when they lie down to go to sleep.
Because the moment you lie down flat, gravity is no longer helping to keep that pool of acid down in the stomach.
Correct. Without the downward vector of gravity acting on the fluid, the incompetent, weakened LES valve is the only physical barrier left to stop the acid from moving horizontally into the chest, and it fails.
So the acid just pours in.
Yes. Which leads to the second major symptom, regurgitation. This is when the patient actually feels, and sometimes tastes, warm, sour stomach acid or entirely undigested food passively flowing back up into the mouth or the back of the throat.
Ugh, that sounds awful.
It is an incredibly distressing sensation.
And the third major symptom listed for sliding hernias is dysphagia, difficulty swallowing. Now, why would acid cause a mechanical swallowing issue?
Dysphagia occurs for two reasons here. First, the normal, straight anatomical path from the mouth to the stomach is now physically distorted. The GE junction is sitting in the wrong place, and the lower esophagus might be physically kinked.
Okay, that makes mechanical sense.
Second, and more commonly, the constant daily acid exposure causes severe inflammation of the esophageal tissue called esophagitis.
Right, the burning.
This inflammation causes the tissue to swell, narrowing the lumen or the opening of the esophagus. Patients describe this as a terrifying sensation of solid food getting physically stuck in their chest or throat on the way down.
Okay, so severe burning, acid washing into the mouth, and food getting stuck. a miserable daily experience, but primarily a chemical burn and structural irritation issue. Let's contrast that sharply with the symptoms of the paraesophageal hernia.
Remember, with paraesophageal hernias, the LES valve usually stays firmly below the diaphragm, but a balloon of the stomach bulges up next to the esophagus into the chest.
Right.
So the symptoms here are almost entirely mechanical. Patients frequently experience severe postprandial fullness.
Postprandial meaning after eating, so feeling incredibly stuffed.
Yes, but inappropriately so. They eat just a few small bites of a meal and suddenly feel completely uncomfortably full.
Why does that happen so fast?
This happens because a significant portion of their stomach is trapped tightly within the rigid chest cavity, physically restricting how much the stomach can expand to accommodate the incoming food.
The balloon is trapped inside a rigid pipe. It physically cannot inflate any further.
Exactly. Then we see severe chest pain. But this is not the chemical burning of heartburn.
What does it feel like?
This is a deep, intense, pressure-like mechanical pain caused by the stomach stretching, expanding, or becoming wedged tight within the diaphragmatic hiatus.
That sounds intense.
It is. This is often accompanied by profound nausea and retching, especially if the stomach begins to twist and obstruct the passage of food. And the absolute most alarming symptom, the surgical red flag, is sudden abdominal distension.
Sudden, massive swelling of the belly.
If the stomach twists completely, a true organoaxial gastric volvulus, gases and digestive fluids cannot escape downward into the intestines, and they cannot be belched upward into the esophagus.
It just fills up.
The stomach acts like a sealed pressure vessel and rapidly inflates, leading to sudden, agonizing distension of the upper abdomen. This is the ultimate red flag for strangulation and impending tissue necrosis.
So you have these two very different, very distinct symptom profiles based on the exact same anatomical weakness. But here is the massive challenge for a doctor in the emergency room. A patient walks in, sweating, complaining of severe chest pain. Our sources highlight a terrifying clinical overlap here.
It's a diagnostic nightmare sometimes.
Right. The visceral hyperalgesia, the chest pain from a herniated, strangulated stomach can perfectly mimic a massive myocardial infarction, a heart attack.
Absolutely.
And on the flip side, the difficulty swallowing, that dysphagia, can perfectly mimic the exact presentation of esophageal cancer. Diagnosis requires a rigorous, systematic approach. This raises an important question. How do clinicians definitively separate a gastrointestinal issue from a fatal cardiac event or a structural anomaly from a growing tumor?
It requires deploying what we call the FRCS level diagnostic toolkit. You cannot just guess based on patient history. You have to visualize the internal anatomy.
Where do they even start?
It always starts with a rapid history and physical examination to rule out the immediate killers. The clinician is actively looking for cardiac red flags. Is the pain radiating down the left arm? Is there an EKG abnormality? That points to cardiac.
And if it's not the heart?
If they rule out the heart, and the patient reports severe postprandial fullness, and the physician palpates extreme, rigid upper abdominal distension and tenderness, that immediately raises the suspicion of gastric volvulus.
But to see the actual hernia, to confirm the architecture, they have to look inside. The sources list several tools. Let's start with endoscopy.
Endoscopy is the frontline visual tool. A gastroenterologist passes a thin, flexible tube equipped with a high-definition fiber optic camera down the patient's throat while they are sedated.
Okay.
It allows the clinician to directly visualize the mucosal lining of the entire esophagus and the stomach.
Wait, let me stop you there. If an endoscopy puts a high-def camera right down into the stomach, why on earth do the sources say we also need barium swallows and CT scans? Shouldn't the camera show us absolutely everything we need to see?
That is a fantastic question, and it gets to the heart of what different imaging modalities actually do. Endoscopy is incredible for surface detail, but it is fundamentally flawed for dynamic structural assessment.
Why is it flawed?
When we do an endoscopy, we have to pump air into the stomach, we insufflate it to blow it up like a balloon so the camera can see the walls. This artificial inflation completely distorts the natural resting anatomy.
Oh.
Yeah. We might completely miss a sliding hernia because we've blown the stomach up. We use endoscopy primarily to assess the damage caused by the hernia, not the exact structural mechanics.
Ah, so it's a damage assessment tool. What specific damage are they hunting for?
They are hunting for the consequences of GERD. They look for esophagitis, which appears as angry, red, actively inflamed erosions and bleeding ulcers on the esophageal tissue. And crucially, they are hunting for Barrett's esophagus.
Our sources label Barrett's esophagus as a precancerous condition. How does splashing acid actually lead to cancer?
This is where we dive into the microscopic, PhD-level pathophysiology. When the lower esophagus is constantly bathed in corrosive stomach acid year after year, the native squamous epithelial cells simply cannot survive.
They just burn away.
They are constantly being destroyed. In a desperate attempt to protect itself, the body alters the genetic differentiation of the local stem cells. The tissue literally mutates.
Mutates?
Yes, it changes from the normal, flat, squamous cells into tall, columnar cells with mucus-secreting goblet cells, tissue that looks exactly like the lining of your intestines, which is naturally designed to handle acid.
Wow.
This cellular transformation is called intestinal metaplasia, or Barrett's esophagus.
So the body basically replaces the lining with tougher cells just to survive the acid bath.
Exactly. But there is a massive evolutionary cost. Because this new tissue is genetically unstable and rapidly dividing in a highly inflammatory environment, it significantly increases the risk of those cells accumulating further mutations.
And that leads to cancer.
Yes, developing into esophageal adenocarcinoma, a highly aggressive, lethal cancer. Endoscopy is the only way to physically see this Barrett's tissue and take biopsies to check for cancer under a microscope.
Okay, so the camera shows you the surface damage and the cellular mutations. What about visualizing the actual displaced structure? This is where the barium swallow comes in.
Precisely. A barium swallow is a dynamic, real-time radiographic study. The patient stands in front of a fluoroscopy X-ray machine and physically drinks a thick, chalky, dense, metallic contrast liquid containing barium.
Sounds delicious.
It's not great, but this heavy liquid coats the inside of the GI tract and lights up bright, opaque white on the X-ray monitor.
So instead of blowing the stomach up with air, you are watching the natural mechanics of gravity and swallowing work in real time.
Exactly. As the patient swallows, the radiologist watches the fluid travel down. They can see exactly where the GE junction is sitting relative to the diaphragm.
So if it's slid up.
If they see the barium-coated junction sitting 2 inches above the diaphragm in the chest, they have visually confirmed a sliding hernia.
And for the other type.
If they see the barium flow down the esophagus normally, but then unexpectedly fill a large abnormal pouch of stomach sitting next to the esophagus in the chest cavity, they have definitively identified the paraesophageal hernia.
It provides a literal, dynamic map of the displaced organs. But what if they suspect the absolute worst? What if the patient is in agony and they suspect a strangulated paraesophageal hernia?
Then they bypass the barium and move straight to the absolute gold standard for surgical emergencies: the CT scan with 5E contrast.
Why a CT scan?
A CT scan doesn't just show the hollow inside of the organs, it provides highly detailed cross-sectional slices of the entire chest and abdomen. It shows the thickness of the organ walls, the surrounding fat planes, and crucially, the blood vessels.
So they can see the blood supply.
Exactly. If a paraesophageal hernia is strangulated, the CT scan will clearly show the twisted stomach. More importantly, it will show if the wall of the stomach is thickening or if there is pneumatosis. Tiny bubbles of gas trapped inside the stomach wall, which is the ultimate radiologic sign of dead, necrotic tissue and impending perforation.
Wow, that's incredibly detailed. And finally, the sources mention 2 highly specialized tests: 24-hour pH monitoring and high-resolution manometry.
These are the data-gathering tools used for complex, challenging GERD cases where surgery is being considered. If a patient is miserable but the endoscopy looks fairly normal, we need hard objective data.
How does the pH monitor work?
A 24-hour pH monitor involves placing a tiny specialized wire probe through the nose and down into the lower esophagus. For a full day and night, it continuously measures and records the exact pH levels, the acidity, correlating massive acid spikes with the exact times the patient presses a button to report pain.
So it proves definitively that acid is the culprit.
Yes.
And manometry.
Manometry is about pure mechanical pressure. A specialized catheter with dozens of pressure sensors is passed into the esophagus. As the patient swallows water, a computer generates a topographic pressure map of the esophagus and the lower esophageal sphincter.
So it's mapping out the muscle strength.
It tells the surgeon mathematically, in exact millimeters of mercury, exactly how weak that LES valve is, and whether the esophagus itself has the muscular strength to push food down. This is critical FRCS level data needed before you decide to operate.
So the diagnostic maze is complex, but the tools are incredibly precise. You have the camera for surface damage and biopsies, the barium for dynamic architectural mapping, the CT scan for catastrophic vascular failure, and the pH manometry probes for pure chemical and pressure data.
It's a comprehensive approach, yeah.
Once we have the map, and we know exactly what is broken, we have to fight the war. Which brings us to medical management, or as we can think of it, chemical warfare.
That is an incredibly apt description. For the vast majority of patients with sliding hiatal hernias, where the primary enemy is acid escaping into the esophagus and causing damage, medical management is the absolute first line of defense.
Right.
The NICE guidelines lay out a very clear, escalating, tiered approach to controlling this chemical environment.
Now, to be clear, the goal of giving a patient a pill isn't to somehow pull the stomach back down into the abdomen. A chemical pill cannot fix a physical mechanical hole in a muscle.
No, definitely not.
The goal here is strict damage control.
Precisely. We are chemically managing the consequences of the anatomical hernia, the severe GERD, to prevent that long-term esophageal damage we just discussed, like Barrett's esophagus and cancer. If we can neutralize the acid, the broken valve becomes much less of a threat.
Let's look at the heavy artillery first. The cornerstone of medical treatment, according to our sources, are proton pump inhibitors, or PPIs. These are medications like omeprazole, lansoprazole, or esomeprazole. How exactly are these drugs working on a cellular level to be considered the absolute cornerstone?
PPIs are remarkably effective because they strike directly at the biological source. The lining of your stomach is packed with specialized, highly active cells called parietal cells.
Parietal cells.
Right. The sole job of these cells is to manufacture and secrete hydrochloric acid. They do this using complex microscopic structures called H+, K+ ATPase pumps.
Literally proton pumps.
Literally. They actively force protons or acid particles out of the cell and into the stomach cavity against a massive concentration gradient. It requires a lot of energy.
So the drug goes in and attacks these pumps. Wait, if I swallow an omeprazole pill, it goes into my stomach. Doesn't the stomach acid just destroy the pill before it can do anything?
That is a brilliant point, and it's why the pharmacology of PPIs is so clever. PPI pills are usually enteric-coated.
Oh, meaning they're protected.
They are designed to survive the highly acidic stomach entirely intact. They pass through into the small intestine where the environment is alkaline, and there they are absorbed into the bloodstream.
Interesting.
The blood carries the drug back to the stomach lining where it diffuses into the parietal cells from the backside. Once inside the highly acidic secretory canals of the parietal cell, the drug becomes protonated. It activates.
And what does it do when it activates?
It forms a permanent, irreversible covalent disulfide bond with the proton pump, completely destroying its ability to function.
Wow. It irreversibly destroys the pump. It just turns off the acid faucets entirely.
It drastically reduces the total volume of stomach acid produced, often by over 90%.
90%.
Yeah. By doing this, even if the LES valve is completely broken and gastric fluid is freely washing up into the esophagus, that fluid is no longer highly acidic. It is mostly just water and inactive enzymes.
Which gives the tissue a break.
This provides the delicate esophageal lining with the chemical environment it desperately needs to heal erosions and ulcers. For patients with severe GERD driven by a sliding hernia, long-term daily PPI use is often entirely non-negotiable.
Okay, but what if the symptoms are milder? What if a patient just has occasional heartburn? The sources mention an older class of drugs, H2 receptor antagonists, things like ranitidine or famotidine.
H2 blockers are a step down in intensity. Instead of destroying the pump itself, they block one of the upstream chemical signals that tells the parietal cell to turn the pump on in the first place.
How's that work?
Specifically, they act as competitive inhibitors, blocking histamine receptors on the surface of the stomach cells. Histamine is one of the primary chemical messengers that stimulates acid production, especially after meals and at night.
So it just blocks the signal.
By blocking the receptor, you reduce the acid output, but not nearly as profoundly or completely as a PPI. They are excellent for milder symptoms or for patients who just need an extra layer of acid suppression right before they go to sleep.
And then there is the lowest tier, antacids. Things like aluminum hydroxide, magnesium hydroxide, calcium carbonate, the chalky tablets you buy over the counter at any pharmacy and chew after a heavy meal.
Antacids are purely reactive. They do absolutely nothing to stop the parietal cells from manufacturing new acid.
So what do?
They are simple, basic, alkaline chemical compounds that sit in the stomach and undergo a basic acid-base chemical reaction, neutralizing the acid that is already present in the stomach at that exact moment.
Ah, so it's a quick fix.
They provide very rapid, almost immediate short-term relief, which is great for an occasional bout of indigestion. But as the NICE guidelines stress to clinicians, they're essentially useless for long-term healing or managing chronic destructive GERD because the stomach will just pump out a fresh batch of acid an hour later.
So we have the chemical warfare sorted. We can neutralize the acid. But pills, as we establish, do not fix the physical hole in the diaphragm. Therefore, lifestyle changes are arguably just as important as the medication.
Completely.
In fact, if you really look at the lifestyle recommendations in the clinical sources, they are not just vague wellness advice. They're actually highly specific physical interventions designed to directly reduce intra-abdominal pressure.
This is a vital concept for both clinicians and patients to grasp. Lifestyle modifications in this context are purely mechanical management.
Let's go through the specific examples from the text and explain the mechanics. First, weight loss. We already discussed how obesity increases baseline abdominal pressure. Losing weight, specifically visceral fat, directly removes that physical downward and inward force on the abdominal cavity, permanently reducing the constant upward push against the diaphragm.
Exactly. It is quite literally removing the mechanical load from the system. Then, the guidelines heavily recommend avoiding large, heavy meals.
Which makes perfect sense physically. If you put a massive volume of food and liquid into the stomach all at once, the stomach has to drastically distend.
It blows up like a balloon.
Taking up significantly more space and increasing the internal pressure. If that distended stomach is pushing up against a weakened hiatus, a massive meal is the exact mechanical trigger needed to force more stomach tissue upward or to forcefully push acidic fluid past the weakened LES valve.
That's why smaller meals are key.
Eating smaller, more frequent meals keeps the stomach volume and therefore the pressure completely manageable.
And then there is the direct manipulation of physics, elevating the head of the bed.
I love this one because it is so elegantly, fundamentally simple. The valve is broken. When you lie completely flat at night, stomach acid flows horizontally right through the broken valve and into the chest.
Simple fluid dynamics.
By simply putting solid blocks under the head of the bed frame, and the guidelines specify raising the frame, not just using extra pillows, which only bends your neck and can actually increase abdominal pressure.
That's a very common mistake people make.
Right, but by raising the frame, you angle the entire torso.
Yeah.
You force the acid to fight an uphill battle. You are actively using the fundamental force of gravity to keep the acid trapped in the stomach during the 8 hours you are asleep.
It is incredibly effective for nocturnal reflux, which is often the most damaging because you aren't swallowing saliva to clear the acid while you sleep. And finally, the guidelines strongly emphasize avoiding specific triggers.
This is where we get into things that directly sabotage and weaken whatever function the valve has left. The sources explicitly state that smoking weakens the lower esophageal sphincter. The nicotine absorbed into the blood directly causes the smooth muscle of the sphincter to chemically relax, destroying whatever barrier function is left.
It's terrible for GERD.
And then we have the dietary triggers: alcohol, caffeine, chocolate, and spicy or highly fatty foods.
These dietary triggers sabotage the system through a combination of mechanisms. Some, like alcohol, caffeine, and theobromine in chocolate, directly relax the basal resting tone of the LES muscle, just like nicotine.
Oh, so they chemically relax the valve too.
Exactly. Others, particularly high-fat foods, drastically slow down gastric emptying. Fat takes a long time to digest.
Right.
The longer food sits in the stomach, the longer the stomach remains distended, and the longer the acid is sloshing around, waiting for an opportunity to reflux upward. So avoiding these triggers is entirely about maximizing the mechanical function of the stomach and protecting the sphincter.
So we have chemical suppression and mechanical lifestyle management. For many patients, that dual approach is enough to live a normal life. But for some, it isn't. The chemicals fail, the mechanical interventions fail, or a catastrophic emergency presents itself.
And that takes us to the high wire act.
The final phase of treatment, the operating room. Let's outline the FRCS level decision matrix. When does a senior, highly trained surgeon look at a hiatal hernia and say, medical management is over, we have to cut? What are the absolute surgical indications?
The surgical notes and NICE guidelines outline 3 primary distinct scenarios where surgery moves from being a potential option to an absolute necessity.
What's the first?
The first indication is the failure of medical management. This means we have a patient whose heartburn, regurgitation, or severe dysphagia is so intense that it is completely destroying their quality of life.
They just can't function.
They can't sleep, they can't eat comfortably, they are constantly miserable, and this is happening despite being on optimized, maximum dose, twice daily PPI therapy, and strictly following all lifestyle modifications. The chemicals are simply no longer enough to counteract the massive mechanical failure of the anatomy.
The second indication is severe GERD complications.
Right. This is when the reflux is uncontrollable, and we are seeing progressive, severe structural damage on endoscopy.
Like the Barrett's tissue we talked about.
Exactly. If a patient is developing aggressive Barrett's esophagus with high-grade dysplasia, meaning their mutated tissue is actively moving toward cancer rapidly because of the relentless acid exposure, we have to intervene surgically to stop the acid reflux definitively.
To stop the progression.
We cannot allow the cancer risk to escalate any further. We have to reconstruct the barrier.
And the third indication, which we touched on earlier, are the absolute emergencies, the life or death complications.
These are scenarios almost exclusively associated with the paraoesophageal hernias. Strangulation, where the stomach tissue has twisted, the blood supply is cut off, and the tissue is actively dying.
That sounds terrifying.
This requires an immediate emergent laparotomy to untwist the stomach and rescue the blood supply before necrosis sets in. Severe, uncontrollable bleeding from the stomach lining or deep esophageal ulcers due to the mechanical trauma of the hernia rubbing against the diaphragm is another, or the ultimate catastrophe, perforation.
A physical tear in the organ.
If the necrotic stomach or the severely ulcerated esophagus tears open inside the chest cavity, highly toxic stomach contents, bacteria, and acid spill directly into the sterile posterior mediastinum of the chest or into the peritoneum of the abdomen.
Oh, wow.
This leads to mediastinitis or peritonitis, massive, overwhelming, systemic, and very often rapidly fatal infections. Surgery is immediately, emergently indicated to open the patient up, physically sew the hole shut, meticulously wash out the infected cavity, and place drains.
Okay, so the decision matrix is incredibly clear. Quality of life destroyed by failed meds, cancer risk rising rapidly, or imminent organ death and sepsis. Now, let's walk the listener through the actual mechanics of the elective reconstructive surgery.
It's a fascinating procedure.
If the diaphragm has a widened hole and the LES valve is fundamentally broken, how exactly do we patch it and build a new valve? Walk me through this procedure our sources call the Nissen fundoplication.
The Nissen fundoplication is, without exaggeration, an absolute marvel of surgical engineering. It is the definitive mechanical fix for a sliding hernia with severe medically refractory GERD.
So what's the actual goal for the surgeon?
The goal of the surgeon is to artificially recreate the high-pressure barrier zone that the patient has lost. To do this, the surgeon first pulls the herniated stomach completely down out of the chest cavity, dissecting away the hernial sac and placing the stomach back into the abdomen where it belongs.
Okay, step one, pull it down.
Then they focus on the top portion of the stomach, a highly flexible, floppy area called the gastric fundus.
Wait, if you just take the stomach and wrap it around the esophagus, doesn't the stomach need that tissue to expand and hold the food you just ate? How do you get enough loose tissue to wrap around another organ?
That is a critical technical point for the surgeon. To get enough loose tissue, the surgeon must carefully divide and cut the short gastric blood vessels.
The short gastrics.
These are tiny, delicate arteries that tether the top of the stomach to the spleen. By carefully severing these tethers and tying them off, the fundus becomes completely mobilized and free-floating.
Oh, I see.
The surgeon then takes that loose fundus tissue and physically wraps it behind and entirely around the very bottom of the esophagus, a full 360 degrees.
Okay, let me bring in an analogy here to visualize this. It's like having a high-pressure pipe joint under your sink that is leaking badly because the internal rubber seal is completely ruined. You can't reach the seal. So you take a thick, heavy, flexible scarf and you wrap it tightly, completely around the outside of the leaky joint, tying it off. You're using the stomach's own natural tissue to create a brand new biological external valve to replace the broken internal one.
That is exactly what is happening mechanically. By wrapping the stomach 360 degrees around the lower esophagus and suturing it securely in place.
Ensuring it's not too tight, right?
Yes, ensuring the wrap is perfectly positioned and not too tight, a technique surgeons often test using a back-and-forth motion called the shoeshine maneuver. The surgeon creates a new high-pressure zone. And here is the true genius of the Nissen wrap. It is dynamic.
What do you mean by dynamic?
When the patient eats, the esophageal muscles push food down through the wrap, and the wrap relaxes enough to let it into the stomach. But when pressure builds inside the stomach from eating a big meal or from bending over or from straining.
Oh, the very things that cause reflux.
Yeah. Exactly. That increased intragastric pressure actually inflates the stomach tissue making up the wrap. The wrap actively swells and clamps shut even tighter around the esophagus. It is a dynamic pressure-responsive valve made of the patient's own living tissue. It definitively physically prevents acid backflow.
That is brilliant engineering. The very pressure that used to cause the acid reflux is now actively harnessed by the wrap to prevent the reflux.
Exactly. Now, sometimes a 360-degree wrap is too tight, especially if the manometry tests we discussed earlier show that the patient has weak esophageal muscles that can't push food hard enough.
What do they do then?
In those cases, the surgeon might opt for a partial 270-degree wrap, known as a two-pet fundoplication, which leaves the front of the esophagus exposed to reduce the resistance. But regardless of the wrap, alongside the fundoplication, the surgeon must also perform the actual hiatal hernia repair.
Because you have to fix the structural defect in the floor that allowed this to happen in the first place. You have to close the hole.
Yes. Once the stomach is pulled down, the surgeon must physically suture the crura, the thick, muscular pillars of the diaphragm that form the hiatus, closer together to dramatically tighten that widened opening.
So they just sew it shut around the pipe.
They use heavy, non-absorbable sutures to pull the muscle tight around the newly wrapped esophagus.
You tighten the hole in the floor so the plumbing pipe fits snugly again.
Precisely. And in many modern cases, especially if the hernia was massive or if the patient's diaphragmatic tissue is very weak, frayed, or thin, the surgeon will reinforce those sutures with a piece of synthetic surgical mesh.
Like rebar.
They tack the mesh over the repair, much like an engineer would use steel rebar to reinforce a weak concrete patch. This mesh integrates into the tissue and significantly prevents the stomach from simply tearing the sutures and pushing through the repair a few years later.
And according to our sources, how are they physically performing this massive reconstruction? Are they opening up the patient's entire chest and abdomen with a massive incision?
Historically, yes, and it was a brutal recovery. It required a massive open laparotomy or thoracotomy incision. But modern surgery relies heavily on laparoscopy. Laparoscopic surgery is the absolute modern gold standard for this procedure.
This is the minimally invasive approach.
Correct. Instead of a foot-long incision, the surgeon makes 4 or 5 tiny keyhole incisions in the abdomen, each less than a centimeter wide. They insert a high-definition illuminated fiber optic camera and long, thin, highly specialized surgical instruments.
And then they inflate the belly, right?
Yes, the patient's abdomen is then inflated with harmless carbon dioxide gas to create a working dome, lifting the abdominal wall away from the organs.
Why is this considered the gold standard? Just for smaller scars?
The benefits to the patient go far beyond cosmetics. The high-definition camera actually provides vastly superior magnified visualization of the deep, difficult-to-reach anatomy right up under the diaphragm than an open surgery ever could.
So they can see better.
They can see the delicate anterior and posterior vagus nerves clearly, ensuring they are preserved, which is critical for stomach function. Because the incisions are so small, there is dramatically reduced postoperative pain, meaning patients breathe easier and avoid pneumonia.
That's a huge benefit.
The risk of major wound infection plummets. Hospital stays are reduced from a brutal week in a bed to perhaps 1 or 2 short nights. And the overall recovery time and return to normal life are vastly accelerated.
And what does that postoperative care actually look like? You just tightly wrap their stomach completely around their esophagus. Eating must be a terrifying challenge initially.
It requires extreme care and strict dietary adjustments. Because the new biological valve is swollen from the surgical trauma and intentionally quite tight, patients will almost universally experience some degree of postoperative dysphagia.
Difficulty swallowing solid foods.
Right. They must start on a clear liquid diet immediately after surgery, slowly progressing to full liquids, then to very soft foods like mashed potatoes or yogurt, and carefully, meticulously moving back to a normal, solid diet over several weeks as the swelling naturally subsides and the wrap settles into its permanent position.
And they need checkups, I assume.
They also require careful pain management and routine follow-up.
The follow-up is critical, right?
Yeah.
To make sure this brilliant mechanical fix actually holds up over time. What are the long-term risks?
Absolutely. The surgeon will monitor for recurrence, ensuring the hernia hasn't pushed back up. They monitor for a rare but serious complication called a slipped wrap, where the stomach herniates through the wrap itself, requiring a second surgery.
Oh, that doesn't sound good.
It's rare, but it happens. And they must help the patient manage issues like postoperative gas split syndrome. Because the new valve is so incredibly good at stopping things from coming up, patients often find they physically can no longer belch or vomit easily.
So the gas just gets trapped.
This means swallowed air gets trapped in the stomach, which can lead to uncomfortable, temporary gas bloating until their body learns to adjust its swallowing habits. But overall, the long-term outcomes are exceptional. It definitively restores the structural anatomy and gives patients their life and their comfort back.
It is a truly stunning journey from cellular failure to mechanical reconstruction. To quickly summarize the immense ground we have covered today in this deep dive,
We covered a lot.
we really did. We started all the way down at the microscopic breakdown of the lower esophageal sphincter and the phrenoesophageal ligament. We explored the relentless, compounding mechanical pressures of daily life, aging, visceral weight, pregnancy, even just the physics of straining that slowly push our vital organs out of their designated places. We navigated the incredibly complex diagnostic maze, relying on barium and CT scans to separate the mechanical symptoms of a displaced, twisting stomach from fatal heart attacks and mutating cancer cells.
And then the treatments.
Yeah, we explored the brilliant biochemical warfare of proton pump inhibitors shutting down acid at the cellular level, and we ended with the high-stakes, brilliant architectural reconstruction of the Nissen fund application in the operating room.
It is, without a doubt, a perfect textbook example of how microscopic structure and macroscopic function are inextricably, permanently linked in the human body.
And for you listening, I want you to remember this. The next time you experience a bit of heartburn after a large, rich meal, you aren't just feeling a minor inconvenience that you can cure with a chalky tablet.
You're feeling physics.
Exactly. You are actually feeling the incredibly complex interplay of fluid physical pressure dynamics, human anatomical engineering, and cellular chemistry happening right there in real time, just behind your rib cage.
And if I may leave you with a final, broader thought to mull over, consider this entirely from an evolutionary perspective. Consider the fundamental structural trade-off of human bipedalism.
Bipedalism.
By choosing to stand upright on two legs millions of years ago, we fundamentally, permanently altered the orientation of our internal organs relative to the relentless downward pull of gravity.
Wow, I never thought of it that way.
We now rely entirely on this single flat sheet of skeletal muscle, the diaphragm, to constantly, endlessly fight against gravity and the weight of our own internal abdominal pressure to keep our organs sorted into their designated cavities.
So it's an evolutionary battle.
Exactly. As we age, as our connective tissues inevitably weaken, conditions like hiatal hernias might not just be a simple disease process. They might, in fact, be an inevitable mechanical consequence of gravity slowly, relentlessly winning the long evolutionary battle against our internal architecture.
Gravity always wins in the end. A truly fascinating place to leave it. Thank you for joining us on this extensive deep dive into the architecture of the human body.